to present the role of anti-VEGF therapy to prevent diabetic eye disease. These are my financial and other disclosures. We know that anti-VEGF is an effective treatment for eyes that have center-involved diabetic macular edema with vision loss, or for proliferative diabetic retinopathy, or even to be used in eyes that have both of these at the same time. An obvious question then is, can anti-VEGF therapy prevent these vision-threatening complications in eyes that are at high risk of developing center-involved DME with vision loss or proliferative diabetic retinopathy? And if anti-VEGF can prevent these vision-threatening complications, is there a visual acuity benefit by 4 years associated with the prevention of these complications? Take this patient, for example, with visual acuity of 20/20. The OCT shows some slight thickening based on population norms, but there are numerous areas of intraretinal microvascular abnormalities consistent with very severe non-proliferative diabetic retinopathy. Over the next 4 years, this patient has a 20% chance of developing diabetic macular edema with visual acuity loss. In addition, this patient has a 50% chance of developing proliferative diabetic retinopathy over the next 4 years, and almost a 60% chance of developing either one of these over the next 4 years. The DRCR Retina Network in Protocol W looked at the effect of anti-VEGF therapy compared with a sham treatment to try to prevent the development of vision-threatening complications, including diabetic macular edema with vision loss, or proliferative diabetic retinopathy, or both. Eyes were randomly assigned to one of these two approaches, and the primary outcome at 4 years was reducing the risk of developing proliferative retinopathy or diabetic macular edema with vision loss. And if this risk was reduced, was there a visual acuity benefit to this preventative treatment? Throughout the study, all eyes were treated promptly if they either developed DME with vision loss or if they developed high-risk proliferative retinopathy. They were treated with aflibercept per the DRCR Retina Network guidelines that are used for DME or proliferative retinopathy. The treatment was given at baseline and then monthly at months 1 and 2, and then in 2 months at month 4, and then every 4 months through month 24. Then, beyond month 24, injections were given if the retinopathy was worse than mild non-proliferative retinopathy. There's a difference between endpoint and treatment in this trial. In terms of managing proliferative retinopathy, the endpoint was developing any one of these features of proliferative diabetic retinopathy, but treatment only was applied if there was high-risk proliferative diabetic retinopathy as defined by the diabetic retinopathy study, or if there was vitreous hemorrhage from proliferative retinopathy. Once initiated, the treatment, as I said, followed the Protocol S algorithm in the DRCR Retina Network. For managing DME, DME with vision loss was defined as an increase of 10% or more in the central subfield thickness from baseline with visual acuity loss, defined either as 2 or more lines, 10 or more letters from one visit to the next, or 5 to 9 letter loss, 1 to 2 lines of visual acuity loss at 2 consecutive visits to be certain that such loss was real. If this did develop, then treatment was initiated per the DRCR Retina Network Protocol T algorithm for treating diabetic macular edema. There were approximately 400 eyes randomly assigned either to the preventative treatment with aflibercept or a sham treatment with prompt initiation of aflibercept treatment if either DME with vision loss or proliferative diabetic retinopathy developed. What were the anatomic results? It can be seen obviously here that the sham group had about a 60% chance over 4 years of developing either proliferative retinopathy or DME with vision loss, and given preventative treatment, aflibercept reduced this substantially to 34%. And this was true whether we looked just at the outcome of proliferative diabetic retinopathy, a 50% chance over 4 years with sham, 28% chance with aflibercept. Or if we looked at the outcome of center-involved diabetic macular edema with visual acuity loss, even though these eyes did not have center-involved DME with vision loss at baseline, having severe non-proliferative retinopathy indicates a high risk of having the macula become diseased in this way in just 4 years. 20% of the sham eyes developed DME with vision loss, and even the eyes that were given preventative therapy, still 10% of those with aflibercept developed DME with vision loss. However, even though there was a substantial reduction of these anatomic severe vision-threatening complications, there was absolutely no benefit for the visual acuity. As long as you promptly initiate aflibercept instead of giving it as a preventative, you can get the same preservation of visual acuity with sham and prompt intervention for either high-risk proliferative retinopathy or DME with vision loss, as you would get if you gave preventative therapy, and if either of those complications developed, you jumped in with additional therapy. This was true no matter how you looked at the visual acuity outcomes at 4 years, 20/40 or better, 20/20 or better, 2 or more lines of vision loss from baseline, 3 or more lines of vision loss from baseline. No matter how you looked at it, the aflibercept prompt preventative treatment was no better, not superior, not safer than just observation, which was sham in this case, and prompt intervention. So what do these mean for people who have very severe or severe non-proliferative retinopathy? The Protocol W conclusions were at 4 years, treatment of non-proliferative retinopathy with aflibercept versus sham treatment resulted in a statistically significant and substantial anatomic improvement, but no improvement in visual acuity. So aflibercept, as a preventative strategy is used in this trial, may not be generally warranted for most patients with non-proliferative retinopathy without center-involved DME. What about our patient? The patient was 20/20, had these high risks of developing these anatomic complications, but as long as we jump in with aflibercept if they develop, the vision outcome would be the same as preventative therapy. Indeed, this patient, 18 months later, developed high-risk proliferative retinopathy and thickening consistent with diabetic macular edema with some vision loss, and so aflibercept rescue therapy was initiated. 24 through 48 months, this patient remains with no evidence of proliferative retinopathy after starting this therapy and remains with 20/20 visual acuity, even though we observed until high-risk proliferative retinopathy developed, or we would have observed until DME with vision loss develops. Conclusion, evidence-based medicine always considers the patient's values, their unique preferences, their concerns, their expectations. What if the fellow eye in this patient had severe non-proliferative retinopathy that was observed, developed a non-clearing vitreous hemorrhage, and needed vitrectomy? Maybe preventative prophylactic therapy might be considered with that individual patient. The results I told you were based on the averages in a trial. That doesn't mean it's unsafe to give preventative therapy in such a case. What if the fellow eye had severe non-proliferative retinopathy and rapidly progressive posterior subcapsular cataract, underwent cataract surgery and developed substantial edema? Maybe prophylactic anti-VEGF might be given before that cataract goes on to cataract surgery. But functional outcomes typically should trump anatomic outcomes, as we will hear throughout treatments of macular disease. As a guideline, not a rule, aflibercept, or even a port delivery system with ranibizumab as a preventative strategy, as used in the DRCR Protocol W or Pavilion trial, generally may not be warranted for patients with non-proliferative retinopathy in the absence of center-involved DME with vision loss. And with that, I thank you for letting me share it with our colleagues in India today.